And we are moving to S27, which we have yet to see this year. And we have legislative council to give us a walkthrough.
Hello again, Jen Carby from the Office of Legislative Counsel. And we'll put the bill as passed by the Senate up on the screen. We are looking at S27, an act relating to medical debt relief and excluding medical debt from credit reports. I think there earlier in the session, there was a press conference on this. This is an idea you'll see features the state treasurer's office and was put forward by the treasurer. So section 1 appropriates $1 million to the state treasurer from the general fund in fiscal year 2026 for the purpose of contracting with a nonprofit entity to acquire and repay certain medical debts incurred by Vermont residents as set forth in this section. It requires the treasurer to ensure that the entity with which the treasurer contracts will purchase the medical debt of eligible debtors from healthcare providers at fair market value, abolish the debt with no cost or tax consequences for the debtor, and coordinate with the healthcare provider or collections agency to ensure that any adverse information resulting from the medical debt is removed from the debtor's consumer credit report following the contractor's purchase and abolition of the debt. There's certain criteria for someone to be eligible for the repayment of their medical debt. They must be a Vermont resident who either has a household income that is at or below 400% of the federal poverty level for the applicable household size, or who owes medical debt in an amount that is 5% or more of the debtor's household income, and the debtor's patient account still maintains an outstanding balance even after the healthcare provider has completed its routine efforts to collect the amounts due. Section 2 would amend a provision that was first enacted a couple of years ago in 2022 in the Budget Adjustment Act, and then has been further amended since then and may actually need to, this provision itself may need to change because of some further amendments since then. But this would be taking that, or funding that $1 million appropriation by reducing the amount of an appropriation to the treasurer's office that would be used to redeem general obligation bonds prior to maturity, basically buy those back. So this would take that, reduce that appropriation from 20 million to 19 million. I think in some of the other bills, money bills that are moving around, that number is changing already. So it is on the radar, at least in the Senate, and we'll put it on the radar in the House Appropriations Committees. But at least the Senate was kind of earmarking $1 million as this bill moves through the process.
Just to be clear, that money was appropriated in 2023.
It was appropriated in 2022 and for fiscal year 2023, I think. So it was appropriated. It was originally appropriated, but it has not been spent. And I'll look now is when I need Becky in the room. I'll look to the treasurer's office. But I think a lot of that money was not spent and has been used for other things through these various bills. You have anything in addition to add, if I can phone a friend?
Yeah, Becky Watson, State Treasurer's Office. So the 20 million was appropriated in 2022. I believe the board in the summer transferred 14 million of that out to be used for 2 other programs. And just the way it's moved so far, my understanding is that the BAA transferred back 14 million to make it whole again, but then the budget transfers out 10 million. So I think the amount that is somehow
We have a chart.
yeah, 10 million. So it would just need to.
Right. So there should be money for this, and it has been identified as a need. But the actual language here in section 2 may need to change somewhere down the line just to reflect the realities of what else has happened with that appropriation since then. All right, section 3. So sections 1 and 2 go together. That's the $1 million to the treasurer's office to contract with a nonprofit that will buy medical debt for fair market value and abolish it with no consequences for the debtor and then make sure it gets removed from credit reports. This is only for debtors who meet certain criteria. Yes,
Do we know what the criteria is?
yes, these were the criteria. They must be a Vermont resident
Okay.
with lower income or higher debt. Yeah, and still have a balance.
There's no thought about what particular medical debt it should be or is.
I will let treasurer's office, I think you're hearing it from them tomorrow, and Office of Healthcare Advocate and others who have been involved in this tell you more about what that looks like.
Okay.
Section 3 adds a new section in Title 9 on the reporting of medical debt information, and it prohibits reporting. So it prohibits a credit reporting agency from reporting or maintaining in a consumer's file information related to a medical debt. And then it has some definitions. So healthcare services, which feeds the definition of medical debt, are services for the diagnosis, prevention, treatment, cure, or relief of a physical, dental, behavioral, or mental health condition or substance use disorder, including counseling procedures, products, devices, and medications. And then subdivision 2, there is medical debt, which is debt arising from healthcare services. So that was the reason for having that definition of healthcare services, including dental services, or from healthcare goods, including products, devices, durable medical equipment, and prescription drugs. But specifically, it does not include debt arising from services provided by a veterinarian, debt charged to a credit card unless the credit card is issued under an open-end or closed-end credit plan offered solely for the payment of healthcare services, debt charged to a home equity or general purpose line of credit, or secured debt.
So can I ask a clarifying question about that? So let's say you're just throwing out your Citibank regular, I don't know, card. It would not mean that, but for something like a care credit, cards that are exclusively used for medical, that would include that?
Yes, that would or could be included or reported or maintained in a file on a consumer. I'm sorry, that could not, that's what's carved out here. So cannot report or maintain in a file on a consumer information related to medical debt. So by medical debt, we don't mean general credit card debt. That can still be reported, but a specific healthcare credit card, as you're describing it, could not be reported, right?
Okay.
Or maintained in a file. So that language is talking to credit reporting agencies. They cannot report or maintain that information in a consumer's file. Sections 4 and 5 really are having to do with the same provision around or similar provisions around consumer credit. So section 4 and 5 are adding a new exception to a general prohibition on accessing a consumer's credit report without the consumer's consent, so that it would allow a nonprofit organization who is requesting a credit report for the purpose of determining eligibility for the abolition of medical debt to pull somebody's credit so that their report so that they can identify the medical debt and eligibility for it to be abolished. And similarly, this is just putting that exemption language into the exemption. So section 4 says, here's what the notice to Vermont consumers looks like. Nobody can access your credit report without your permission except under certain circumstances. And it adds that pull of the credit by a nonprofit to determine eligibility for abolition of medical debt as one of those exceptions. And then section 5 is the actual exception. So section 4 is what goes in the notice to consumers. Section 5 is the exemption itself.
Would this, Woody, go ahead. I'm sorry.
Well, you go, you were.
No, well, I'm just thinking, this would mean going forward, you could not report to a credit reporting agency, and it wouldn't be on your credit report, but would it abolish things that have already been reported if that medical debt was subsequently then paid off, would it remove it
I
from?
believe it does remove it. I believe that was part of the language in section 1 about what this report, what this organization is doing, is they're coordinating to ensure that any adverse information resulting from the medical debt is removed from the debtor's consumer credit report once the medical debt is gone.
Great, thank you. I'm sorry, Woody, go ahead.
Well, I think this would be unethical to do, but it's probably has been done. Are there any services that must be paid before treatment? And I guess the reason I asked that question is based upon this notice to Vermont consumers. Why would you even check a credit report beforehand?
So there are general prohibitions on anyone pulling your credit report without your permission, except under certain circumstances. And this is creating an exception to that. Nobody can pull your credit report for this medical debt abolisher, to be able to pull your credit report to see if you have medical debt, or if you meet the criteria for, so not just necessarily you have medical debt because that's not getting reported anymore, but if you meet the eligibility criteria in order to have your medical debt abolished.
But what I'm getting at is, can you be denied services before you actually pay for treatment?
I think it would depend on the setting. So I think, and I'd look to Devin and others, but I think under EMTALA, no, you couldn't be denied emergency medical treatment at a hospital.
You could not be.
But could you be denied elective treatment if you had an outstanding bill? I don't know. I think you'd have
Cancer
to.
treatment or whatever.
I'm going to defer to other people. I see some nodding happening behind you, so I think perhaps yes, but the Office of the Healthcare Advocate is up next.
Okay, I can wait.
Great. All right. Then we get to section 6. Section 6 is amending a provision in Title 18. There's a subchapter that was added a few years ago for those of you who were on the committee when you worked on patient financial assistance policies, and this would specifically add medical debt to the name of the subchapter. And then an existing section that prohibits the sale of medical debt. It would also prohibit reporting of medical debt. In this case, it prohibits a large healthcare facility, which is defined in this subchapter, but is largely hospitals and ambulatory surgical centers. No large healthcare facility shall sell its medical debt except as provided in subdivision 2. And then the new subdivision 2 says, except they can sell or otherwise transfer medical debt to a nonprofit organization for the specific purpose of that organization abolishing medical debt of the patients by canceling the indebtedness. And then in subsection B, no large healthcare facility or medical debt collector shall report or otherwise furnish any portion of a medical debt to a credit reporting agency. And in this subchapter, medical debt is debt arising from the receipt of healthcare services. And the act would take effect on July 1st.
Leslie, I'm just curious to know what large means.
Well, that is in the definition of
the
large. No, you
definitions?
can't see it. It's just what I was referring to that's defined in this subchapter. So give me a second and I will pull up that definition. As I said, it's largely or mainly hospitals and ambulatory surgical centers, as I recall, but I don't remember what the specific phrasing was that we used.
Because in Vermont, I'm just wondering what's considered large.
Right. Well, it's however you define it. Whoops. So definitions,
Yeah.
large
Yes.
healthcare facility. Yes, it's any hospital. So here, I'll put this definition up. So under existing law for this subchapter, a large healthcare facility is a hospital, outpatient clinic or facility affiliated with or operating under the license of a hospital and an ambulatory surgical center.
So it's basically everybody. Could we say that?
Well,
Or not?
no, I mean, I think it's
Any hospital?
hospitals. Yes, it's hospitals and their affiliated clinics and outpatient ambulatory surgical centers. It's
Okay, it
not,
wouldn't be independent.
right,
but-
it's not independent,
Got
it's
it.
not FQHCs,
Yeah.
it's not walk-in clinics that are not affiliated with a hospital, et cetera.
Any questions for Jen? I just have one, but on page 2, line 21, going on to page 3, healthcare services. Does this definition of healthcare services, would it exclude cosmetic?
I don't believe so. Page 2. Okay, definition of.
'Cause I'm just thinking what a condition or a disorder would be.
No, I mean, this is generally our fairly large definition, broad definition of healthcare service. So no, I don't believe it. I mean, it is not intended to carve out any services provided by healthcare providers and facilities.
I'm just thinking if you used like care credit for cosmetic procedure, say my neck lift that we all know I want to have.
Oh,
at
I
this
do.
point.
Yes. I'll feel bad about my neck.
My neck lift. Sorry.
Or a mastectomy.
If I used my care credit for my neck lift and then I didn't pay my care credit card, that would be eligible to be assumed.
I think if you met the
Take it
criteria of someone with a household income at or below 400% of federal poverty level, or you owe medical debt that is 5% or more of your household, and you have not paid under the terms of this language, yes, I don't know if there would be any further scrutiny as part of the work that this organization does. That may be a question better asked to others.
I just wanted to see if it was.
It's not, I don't believe it's obvious. I don't believe that it's excluded by the terms of the language.
Don't make your appointment yet.
All right, and Leslie, I'm sorry.
So I'm just wondering about how this gets done. Like, where the rules making, where does that land?
There's not rulemaking required. It directs the treasurer to contract with an entity that does this. There is an entity that does this. Maybe you'll
Oh,
be hearing
that's
more
right.
about
But then
it.
how do people hear about it? How does that get?
I think that's where the allowing the soft pull of your credit comes in. But again, I will defer to others who are more in the weeds of the operations.
Okay, that's what I was curious about.
Yes, would you like, while Becky is here, because I know she may not.
We,
Be here for all of it?
We have the treasurer coming in tomorrow,
Yes.
because I don't think he was able to make today. But if Becky, if you wanted to just really quickly.
Yeah, quickly, there's no application for it. The nonprofit that does this work identifies the patients who are eligible, just abolishes their debt, and then they get a notification that says your debt is filed.
And how do you get identified? How do you get found?
The nonprofit will contact providers that want to do this, and they will, through their patient files, give them over to the nonprofit. They will identify based on the criteria and just abolish the debt.
So like, just for example, Springfield, they would contact Springfield Hospital and say, do you have, what's your group of people who have this debt? And we want to, okay.
Right, although they enter into a contract with them first to make sure they're, sharing information.
Yeah, I mean, it's not appropriate, but that would be a direct relationship between the nonprofit and a large.
Thank you,
All
Jen.
right.
Thank you. Mike, you want to follow up? Oh, and Emma. Emma's coming up too?
That's.
Yeah, Emma.
Good afternoon, Mike Fisher, healthcare advocate.
Anna Zaves, health policy analyst. Good to see you all again.
I'm happy to be here to talk about S27. And yes, whenever I can bring a staff person with me to make sure I'm honest, someone who really knows what they're talking about. I wish I was thinking of those things down here that I wish I had an April Fool's joke at the beginning, but it doesn't really work from the witness seat.
Second.
And someone who
All
can
right.
run IT.
Good job. All right, let's dive in.
So we're here, here's just a little brief review of what we plan to do today. We want to say we support the bill. We think whenever anybody brings concerns about medical debt and advances the conversation about medical debt in the public, that's a good thing. So we appreciate the Treasurer's Office for bringing this forward and all of their public work on it. We think that's a good thing. But we also want to recognize, while this is a good bill and it will, we believe, relieve some stress from Vermonters, it doesn't address the structural problems. And there are structural reasons why people have medical debt. It shouldn't be a surprise to us. It's actually designed in our system and very predictable in our system that people will need care and who can't afford to pay for it and who don't have the sports to be able to pay for it. So I wanted to make that clear statement that while we support it, we always think there's more work to do. And we've also done some good work in this space.
Yeah. So we're going to talk about medical debt in Vermont to just ground us in that conversation, and then recent legislative action that the House Healthcare Committee and the whole legislature took in 2022. And then we'll dive into the bill that's before you today, S-27. And last, we'll talk about some other state like best practices that we've seen in other parts of the country. So this is a map. You may have seen it before. It was a study that was conducted between 2019 and 2021, looking at the share of medical debt, significant medical debt for adults in states. I believe that was over $250 held by an adult. You can see Vermont is not the darkest blue, but it's up there. It's the second darkest blue. And Vermonters had 12-point-something% of adults in the state at that time held significant medical debt. And we believe that that is probably an undercount. And this is a couple of years old as well. But to set the stage, medical debt is a huge issue for adults all across the country, and Vermont is on the higher end of that.
So a couple of years ago, we did a storytelling project where we reached out to Vermonters and asked them to tell us about their experience with medical debt. And this word cloud here is, these are the words that people used in describing the impact of medical debt. And I just think it's important to pause for a minute and recognize the difference between other types of debt and medical debt. I think I, for one, sort of personally believe that poverty is also structural and that debt generally has a structural component to it. But there's something tangibly different about debt that you have because you purchased something you couldn't afford and debt that you have because you or your loved one got sick and needed care. It's just something entirely different about it. I know in this country, we have this pull yourself up by your bootstraps and be successful because of your own will and fortitude. But people who have medical debt didn't make a mistake. They didn't, overextend. They just got sick. So that makes this topic really different from other types of debt. We've got a lot of medical debt in our system. This is from the lens of hospital budgets. System-wide in 22, hospitals wrote off about $100 million of bad debt. So that's from the perspective of the budget makers in the hospital. They're saying system-wide across all the hospitals. In that year, they had $100 million of revenue on the books that they had to take off their books because they're not expecting to get paid. And then you can also see free care, which in that year was just under $40 million. I know that I can't remember the name of the entity that the treasurer's office is.
Undue medical
Debt has estimated the amount of medical debt that there is here in Vermont. And that estimate, I think, is significantly less than the amount that we believe there actually is. This is just 1 year. It happens every year. And so there's a lot of it, is our point.
This is in totality, it's hospitals, private clinics.
No, good point. Thank you. This is hospitals.
Okay.
I've asked myself this question, in the household, in the expenditure analysis, we estimate that about 38% of healthcare spending, it happens at, 40% happens at Vermont Hospital, something like that. And so the remainder happens at hospitals out of state or at non-hospital providers. So I don't know how to back in, Representative Cordes, to, how much medical debt happens at non-Vermont hospitals. There's different dynamics. Non-Vermont hospitals don't have EMTALA. They don't have to treat. They can also, in a very different way, fire people for not, discharge them from service, for not, if I'm to use the right term, for not having paid their bills. So I don't think it's exactly proportional, but for sure, there's a great deal of medical debt that happens at non-hospital providers.
All right. So I want us to take a trip down memory lane. Back to 2022, this committee was very important in passing H287 then, which was Act 119 of 2022, an act relating to patient financial assistance policies at hospitals and medical debt protection. So while it was signed in 2022, it actually just went into full effect this last summer, so July 1st, 2024. And that act prohibited the sale of medical debt by large healthcare facilities, so hospitals, and it also set minimum standards for financial assistance programs at Vermont hospitals. Before this act became law, hospitals across Vermont, all of our hospitals are nonprofits, and under the IRS rules, you get the tax breaks in exchange for giving community benefits like financial assistance, but there aren't like stringent standards of how much you need to give and how to define different things. And so hospitals across Vermont had financial assistance policies that differed from each other. They use different definitions of who is a Vermont resident and what income counts. And they set different discount levels. So what this act did was it standardized the definitions across the board so that no matter where you live in Vermont and what hospital you go to, you'll be treated the same in terms of them assessing if you qualify for help. And it also set a minimum standard for free care and low-cost care. So for free care, 100% discount is given to folks who have income between 0 and 250% of the federal poverty level. And for low-cost care, a minimum of 40% discount for folks between 251 and 400% of the federal poverty level. And that's minimum. So of course, hospitals can be more generous and some of them are. But this really leveled the playing field and created some guarantees for Vermonters, again, kind of no matter where they lived. A lot of issues.
All right. Just a personal note, I don't often get to see the work of this committee routinely in my daily life, but in my other role as a nurse at UVM, every patient I discharge, and this happened yesterday, I get to go over a two-sided document that describes this for every patient that's discharged, and that makes me happy.
I think that might be the template we created.
And it's really good for us to hear about it in practice. I think I want to recognize that this was an effort in collaboration between the HCA and the Hospital Association that delivered this to the committee. we put a tremendous amount of effort into helping and controlling and pushing hospitals to being compliant with it. And, you know, that hasn't been, you know, absolutely smooth, and it's an ongoing process. But you know, it takes a while for these things to really be put in play. I want to, I guess I want to recognize there's a sort of an unstated agreement. I don't know if it's unstated, but there's something of an agreement that I think the Hospital Association and the HCA both find ourselves with. And that's that we want to live with this for a little while. Just went into effect. We want to live with it for a while before doing any changes to it, really. I think we both would come to you and say, hey, this wasn't addressed, or this isn't right, or we should do this in addition. But even before the instability in our healthcare system that we find ourselves in now, we wanted to live with it for a little while before making changes. And let's recognize there's a lot of instability in our healthcare system, both for people needing care and for hospitals and other providers who are attempting to give care. So even more, I think you'll see some additional suggestions that we think the committee should go to at some point, but we're not asking you to go to them today. But these we are asking you to do.
Turning to the bill in front of you, yes, for S27. Do you want to just?
No, you.
Okay. So we have a couple of recommendations for improvement. Like Mike said, at a high level, we support this legislation, and we just have a few ideas that we think would further its mission. So our first recommendation is to add a noticing requirement to the bill to inform patients about hospital financial assistance programs in Vermont. So the bill before you, S27, would direct the nonprofit entity, likely Undo Medical Debt, to abolish debts for folks in Vermont whose household income is less than 400% of the federal poverty level. 400% of the federal poverty level and less are also people who would qualify for financial assistance now going forward at Vermont's hospitals. And this entity will have to send a letter to those Vermonters who have debts forgiven anyway. So we think it would be an easy win to include information in that letter to say, hey, we think you are under 400% federal poverty level. And if you are struggling with your healthcare costs and accessing costs now, there is this thing called financial assistance. We think you might qualify, and here's how to get more information. So feels like a low-hanging fruit. Go ahead.
Who would be implementing all that information?
Oh, I believe the treasurer's office, I think you'll hear from them in another day or two, has a nonprofit entity in mind that has worked with municipalities and states across the country called Undo Medical Debt. I think in the bill, it just says nonprofit entity. But
Well, this sounds like this might be not a one-time thing.
well, I'll let the treasurer's office speak to that. I mean,
It's a good question. Okay.
yeah, that's a great question. And ultimately, I mean, our thoughts in making this recommendation is that, you know, we hope that people aren't continuing to accrue more and more medical debt. So if S27 is sort of appropriating money to buy and eliminate medical debt, past debts for people, we want to set those people up for success going forward. So we don't want them to just reaccrue more medical debt. So if they are very sick and they need treatments and they're going to be accruing debt now going forward, we want them to reach out to their hospital to explore financial assistance. So it seems like the right balance in terms of looking back, but also just setting people up for the future. Okay, that's our first recommendation. Any other questions on that one? Our second recommendation, I'm going to keep cruising. Okay. Our second recommendation is to encourage this nonprofit entity, likely Undo Medical Debt, to at least explore purchasing medical debts arising from non-hospital providers in Vermont and out-of-state hospitals that serve Vermonters. So as was previously alluded to, people, you know, acquire debts from independent physicians, dentist office, ambulance companies, name it. Lots of healthcare services are delivered outside of the hospital system. And those entities, for the most part, don't offer financial assistance. Obviously, your federally qualified health centers do offer some level of financial assistance. And then also many Vermonters receive healthcare services out of state, so at Dartmouth Health or in Massachusetts or New York. So just encouraging essentially the nonprofit entity to broaden the healthcare providers that it works with. And another note, I should say, is that we think that part of working with those entities is that those entities should agree to take those people back as patients if they wish to be served there. Many entities will stop serving people if they owe money for services. And I think it's important that if you're getting money to eliminate these steps, that you agree to serve those patients in the future.
Right?
On your previous slide, you pointed to a specific piece in the language where you would recommend a change, and I don't see that on this slide. Is there a particular part of the bill where you would see this fitting in, or would we need to create another section?
I mean, I think we're at this moment flying high about a concept, and if the committee's interested in doing this, we would engage with Vice Counsel.
Yeah, absolutely. All right, our third recommendation is asking for a clarification in existing language from S27. So the bill before you says essentially that, let's see, disclosures to consumers, that a 501c3, a nonprofit, let me just read it. The request for a credit report is by an organization that is exempt from taxation under Section 501c3 of the IRC for the purpose of determining eligibility for the abolition of medical debt. We would like to clarify that a credit report may not be pulled by a large healthcare facility for the purpose of determining the income or credit worthiness of a patient applying for financial assistance. Go ahead.
Can I ask why?
Sure. Yeah, that's perfect. That's where I was going. So in Act 119, we were very, 2022, so the financial assistance bill, we were very clear that hospitals should be all sort of playing with the same documentation, verification, and that a patient can provide their tax return, or if they don't have a recent tax return, that they could provide pay stubs or other types of documentation.
They would provide.
The state. Oh, yes, absolutely.
Okay.
But that hospitals, and this is something that we saw in some of the old financial assistance policies. So before Act 119 was implemented, some hospitals would pull credit reports on people to see, like, are they worthy of financial assistance? And in Act 119, we collectively as a body decided, like, no, we should just be looking at somebody's
That might not be a bad idea.
Well,
There's some on the other end that might be more deserving.
you never know.
I mean, one of the things we tried to do in Act 119, because we saw evidence of this, is that the documents required to show income were burdensome in a way that kept some people from being able to apply. And so having a really sort of, clear, your last tax return, the extent that you can't produce the last tax return, the set of documents that are required for people to, for a hospital to access the person did that.
I think, Brian, but I'm confused really quickly about something. I just want to clarify
What did you see?
some confusion. So right now, there's the only thing that the bill is doing is it is adding an exemption for this nonprofit entity, let's just call them undue.
Yeah.
To be able to pull credit reports. But there is nothing right now that allows a large hospital to be able to pull a credit report. So why do we have to make an exemption
So we are more so
or an exception?
or suggesting that we tighten the language because
Mm-hmm.
reading this, we're concerned that this could mean more than that nonprofit entity undue medical debt. that a hospital could read this and say, I'm a 501c3.
Okay.
I'm working on abolishing medical debt by giving financial assistance. I'm gonna start pulling credit reports again. And that sort of circles back to, I think, what Mike was saying in the beginning, which is that medical debt is a particular kind of debt. People are just sick and need healthcare. It doesn't go to whether they're deserving or undeserving, et cetera.
That clarified for me. Thank you.
Okay, okay. Yeah, so we just wanted to make sure that it's, that the intention is clearly articulated.
I just wanted to clarify that when a person's credit report is pulled, that's tracked, and does that affect their credit score the more that they get pulled? Like if could a hospital or another organization pulling someone's credit report negatively affect their credit score in addition to any debt they have? And
You are well outside my expertise as a healthcare guy. It's a good question.
I
don't
think
know.
we're onto something.
that's the question, but.
Yeah.
Thank you.
Yeah,
Thank you.
we think that the Act 119 verification documents that's a good process, and we should not be broadening that to allow them to pull credit reports in that way. All right, our fourth recommendation. You want to do this one?
We don't know whether anyone is going to propose to change the definition of medical debt in 4981, but have heard that there might be proposals like that. So haven't gone first. We don't know whether someone will come after us to say that they want to change the definition of medical debt in this statute. And so we just wanted to put a mark in the ground that we don't think it should be changed. We think it's working well, and we don't think there's a reason to change it. And what I said earlier, you crack open this door and you get the hospital association and the healthcare advocate battling in front of you all day about other things that need to be done. And I don't think that's what this bill is for. And I think we should steer clear of it.
Bless you. All right.
So the rest of the slides are sort of going back to what I said earlier. There are structural reasons. There are further protections and there are structural reasons for medical debt. And we wanted to let you know that other states have moved further than Vermont. And we think that there's room for improvement in a future year. And we wanted to, Emma had done some research on it, so we wanted to make it available to the committee. But we are not suggesting that you add these to this bill.
Yeah.
We just wanted to make sure you were aware of.
Yeah, this is more food for thought as we continue to think about medical debt and work on this issue in coming years. So a couple of practices I wanted to highlight. We could consider in future years prohibiting Vermont hospitals from engaging in extraordinary collection activities. Some of Vermont's hospitals do not and explicitly acknowledge that they do not, and some do. Extraordinary collection activities are things like placing a lien on an individual's property, seizing a bank account, causing an individual's arrest. That's a pretty crazy one. Garnishing wages, that type of thing. And
that reminds me, I want to say in the interim, if there's work that can be done outside of this process with the hospital association to help those hospitals change their policies, we would certainly engage.
Brian.
So wait, those are examples of collection activities that have actually happened to people recently?
Well, sorry,
We don't
that's
know.
part of the definition of it.
Okay.
This is the definition of it, what an extraordinary collection activity is.
Okay.
And some hospitals explicitly say, we don't do those things. And some hospitals say, yeah, we do those things.
Or we might do that.
Or we might do
If the
some of
threat
those
hangs
things.
over a person's head that a lien could be put on their property.
Yes.
Okay, yeah, it makes my heart drop.
Yeah.
That list, like,
Yes,
if you're
yes.
sick and then be threatened with that.
Yes, every hospital has a credit and collections policy, and so they spell out
Okay.
what actions we would take. And so some of them say they don't do this, some of them say they do, et cetera. And so one thing we could consider as a state is saying, no.
Thank you.
That's in Vermont, that these things are happening in Vermont.
We really don't know.
Okay,
Yeah.
I'd rather not know. No, I don't want to be an ostrich, but on the other hand, if it's happening, then we need to know.
Yes,
I
yeah.
think what Representative Chena said is more accurate. I think that there is a concept of a threat, not in some policies that would be good to eliminate, not suggesting that those hospitals, we don't know that those hospitals are actually doing it.
Could you say, oh, sorry, can I ask?
Yeah, go ahead.
Can you say something about the impact of financial stress, like the threat of these, how that can affect the health outcomes for a person? If you can't.
I mean, I kind of want to go back to, I would ask you to go back to the slide that has the word cloud on it and look at the words that people use to describe what medical debt does in their lives.
Okay.
There's a lot of emotion words in there, and there's a lot of, fear and anger and, for sure, we hear from Vermonters who not only have the, incredible challenge of, and fear about their own illness or loved one's illness, but also just being baffled about how they're going to possibly pay the bill. And yes, your point is well made. It creates stress in people's lives.
And perhaps we can have a witness at some point who could talk about the impact as a social driver of health that financial stress has. Because maybe you're not the right witness to ask that of. But I appreciate you referring to the qualitative data you collected in the word cloud.
Speed through these.
Okay, yes.
Good.
So one more is consider implementing the best practice of screening patients for financial assistance prior to receiving their first bill. So as an example, the state of Oregon passed a law in 2023. So hospitals there screen people for financial assistance if they are uninsured, if they're enrolled in the state's medical assistance program, or if they owe the hospital more than $500. So it kind of moves the onus from sort of the patient to the hospital to say that like you should proactively screen these people. So that's another consideration. And these last few slides are just resources. They just point out sort of what types of practices are allowed in different states. So preconditions before a hospital can send a bill to collections, state limits on wage garnishment to collect on medical debt, state limits on liens and foreclosures to collect on medical debt. So you can see that some of these policies and laws are sprouting up in different areas. And so they're things that we could consider here in Vermont. Again, not for S27, but for the future of sort of where we look to in terms of medical debt. Cheers. Yeah.
Getting back to those consider and implement practices where you said look at maybe screening for uninsured. Sometimes we try to be nice and considerate and we don't realize the unintended consequences. But if you're looking, one of your screening things would be, looking at the uninsured, maybe I'll drop my insurance and save that premium. I don't show much income. I'm retired to live alone, Social Security. This job hurt me. But you gotta remember all the unintended consequences, what we're trying to do here. So
Yeah.
I think that's a
Yeah,
concern for
I think
me.
that's a good point, and it reminds me that I do want to spend at least just a moment to sort of describing the perspective we hear from Vermonters. Everyone's got a story about a Vermonter, about somebody who's cheating the system, and for sure there are people out there cheating the system. I'm not going to dispute that. The Vermonters we hear from really appreciate their providers.
Mhm.
They really are thankful for the care they got. And they feel desperately horrible that they don't know how to pay the bill. And so it's just important to speak to that side too.
And that's the ones that this bill should be all about.
I just reminded of something when you got to your last recommendation, and I'm having flashbacks to, what's the act number?
The 19.
The 19.
Did you record?
I reported that. There was also, aren't hospitals required to, even with that, you listed the discounts, but also it was that they had to offer reasonable payment plans that could not exceed more than a certain percent.
Yes. And folks who qualify for financial assistance, so if you don't qualify for 100%, you just qualify for like 50% discount. So you still owe maybe 100, even thousands of dollars if you had a huge bill.
Most of your recommendations are the premise of people don't know what they're eligible for now, and that we should be moving to more reach. It should be presumed.
Yeah.
And
Improve communications, improve.
Yeah, we talked to a lot of people who are like shocked and overwhelmed with joy when they learn that they would qualify for financial assistance. And we'll say, when we talk to people who, were informed by the hospital or the billing office of financial assistance, and we talk to people who are like, I have called so many times, I've tried to, work out a payment plan, I've tried to do all of these, I'm so stressed, and nobody ever told them about financial assistance. So education and outreach, since there isn't a requirement that hospitals screen everybody, education and outreach is sort of the first line of getting the message out there for folks.
And not to testify, but I will just say I spent a career in medical debt collections, and people, they run the gamut of what you can expect, but a big overarching thing is, if I don't think about it, it'll disappear because it's too overwhelming. It's too overwhelming to think about it. So a lot of people just don't do anything, even when that help is available. Mari, I'm sorry.
Keeping it at the conceptual level, and the slide about additional considerations and the Oregon bill about screening. And then that brought up the discussion about whether the person is uninsured. Isn't it true in Vermont that one of the bigger problems is people that are underinsured? So people that do purchase some sort of health insurance plan, but the deductibles are so high and the cost sharing is so high that they can't.
As a percent of their income.
Yeah.
Yeah, that's a great point. And a good clarification is that the financial assistance that hospitals give can go to somebody who is uninsured, but I guess we don't have the numbers, but my guess is that it's the majority of people are insured. They just can't afford their $10,000 deductible.
They are insured.
Yes, they are. They have insurance. And so financial assistance helps people with the cost sharing, with the deductible, with the co-pays, so that they can actually use their insurance and get the care that they need.
So the last household health insurance survey, I think it was 44% of Vermonters, of commercially insured Vermonters, under 65, I think it was, are considered underinsured by the standard in the household health insurance survey. And let's just recognize, we may have today one of the best, better subsidies and better supports in the commercial market than we ever had. And the household health insurance survey, I think Jesse Hammond, whose point on it, spoke earlier today, just said that that's the survey's been completed and they're working on the data. And we're going to have a new read on our uninsured and underinsured rate soon. I have one more suggestion for the bill, one more statute language change that I'd like to suggest. And you get one guess as to which legislature reminded me about this. In the definition of healthcare services includes the term behavioral health. And I agree that it is not needed and that it is not considered, it is offensive and not considered respectful to some people. And because it's not needed, there's no reason to include that word. And so the very last line on page 2 includes the word behavioral, and I would suggest that we delete that word.
I think it's in here twice, isn't it, actually?
I only see it once.
You get a prize if we guess who told you.
Thank you. Any questions for, I'm sorry, were you? Any questions? Or, oh,
What's
Wendy.
New York and California doing so well? I was gonna ask that, but it sounded that wasn't there.
Massachusetts doing.
And Massachusetts, yeah.
Yeah.
Medical program, right?
Is that it? Is it Valley Med or whatever it's called?
Medi-Cal,
Medi-Cal.
California, New York has a basic health program which provides Medicaid-like coverage up to 200% of the federal poverty level.
250, can't we say?
No, it's now 250
Wow,
actually as of this year.
It's Vermont.
138?
138. So there are definitely states that are taking strides in the direction of affordability, and things to learn from some of those examples. And we'd be happy to come back and talk about those some other time.
We tried.
And are those benefits under threat if Medicaid gets cut at the federal level?
Well,
Yeah.
everything's under.
Yes.
Yes, unfortunately, but yeah, they all tie into federal money, so.
Thank you.
Thank you.
So much.
Thank you.
Do you have one more question, Ellen?
No.
You're good. Okay, yeah.
You got 4 or 5. but not right now.
The door and wait.
Thank you.
Jill, you can't
No,
open
the door, I
it.
can open it and go like,
Too noisy.
okay.
Anyways, thank you. Ernie Davis, thank you for joining us.
Thank you for having me. So my name is Ernie Davis. I'm the Senior Director of State Government Affairs for the Northeast for the Leukemia and Lymphoma Society. And I'm pleased to submit testimony in support of Senate Bill 27. At LLS, our mission is to cure blood cancers and improve the quality of life of our patients and their families. We exist to find cures, ensure treatment access, and improve survivorship for blood cancer patients. The average cost of the first year of treatment for a blood cancer patient averages $470,000. Last October, LLS released a poll that over 90% of US adults agreed that elected officials should pass policies that protect people with serious illnesses like cancer from medical debt and harassment from collection agencies. LLS is leading or part of coalitions working on medical debt legislation in dozens of states nationwide, specifically in other Northeastern states, Rhode Island, Massachusetts, Maine, Connecticut, New Jersey, New York, and Pennsylvania. I myself have actually worked on those pieces of legislation and want to thank the healthcare advocate for talking about some of the extraordinary collection practices, which in some of those states we have addressed. And certainly happy in the future to work with the committee and sponsors on knocking some of those out of the box and making those prohibited in Vermont as well. The CFPB recently released a report and determined that medical debt is the #1 reason for individual bankruptcy and that medical debt is the least predictive indicator for future repayment of all debt. Medical debt, which is a debt that is not a willing choice and is sometimes made under the duress of life or death, is widely accepted to have the most mistakes due to lack of notification, billing errors, coding errors, and difficulty for the patient in appealing. This often inaccurate medical debt reported on credit reports begins the downward spiral of negative consequences in securing future employment, housing, and other credit opportunities that literally affect generations. 2 months ago, the CFPB actually urged states across the country, certain states, to continue passing medical debt policies at the state level, most notably the prohibition of reporting medical debt to credit bureaus or credit bureaus being able to use medical debt on people's credit scores and on their credit reports. When patients can afford their medical treatment, health outcomes do improve. We urge the committee to pass Senate Bill 27 And I'm certainly happy to answer any questions you may have about this bill or what my experiences have been in other states as well. And we worked with the sponsor and the treasurer's office on some of the language in regards to the reporting of medical debt to credit bureaus, which is similar language to language that I believe Maine had last year.
Any questions? Mr. Davis? I think you bring up a great point that sometimes we don't think about when we're talking about medical debt is the impact to your credit score, which then impacts everything else. So if you try to go get a car loan, and even if you qualify, your interest rate is higher, your housing is higher because you're paying a higher interest rate.
Yeah, and it literally affects generations. And on that point, a previous member, and I apologize, I couldn't quite see who it was, had a question about a soft pull versus a hard pull on a credit report. There is such a thing as a soft pull, which does not affect your credit score, which is what Undo typically does when they're taking care of that, and a hard pull, which is what others do. But Undo does a soft pull, and I think that's what we're pulling for, so as to not affect an individual's credit score, but allow them to certainly take advantage if they have, it's part of the medical debt payment program.
Thank you. Any questions? Well, thank you for joining us. We
Thank you.
appreciate it. Devin? Ms. Green?
Good afternoon. Devin Green, Vermont Association of Hospitals and Health Systems. VAS supports this bill, and we appreciate the Treasurer's Office work on it. And so we support the bill as written, and have really no other comments on it besides support. I will go into a little bit as to what the Healthcare Advocates Office spoke about in terms of their recommendations. First, I would agree with them that, and I appreciate all the work they've done on Act 119. They've actually been really helpful in answering hospital questions around that and providing clarification and templates. And it is a process, and it does take time, and I appreciate all their work on that. So I would ask that we let Act 119 keep moving forward as it is in this moment. For the healthcare advocates, recommendation number 1 with the notice requirement, we are fine with that, having a notice requirement from undue medical debt. For recommendation 2, to encourage undue medical debt to purchase debts from other organizations, we're neutral because it doesn't impact us. For recommendation 3, clarify that a 501c3 cannot be pulled, the credit report cannot be pulled by a large healthcare facility. I am going to go back to my members on that one and just check with them. I will check on that. It's possible it would make more sense to say unless permitted to do so or something to that effect, to give the option to patients if they actually want that available to them, if they don't have documentation or something like that. But let me check with my members on that recommendation. Recommendation 4, definition of medical debt, keep it the same. We support that piece. And then recommendation around the prohibition on engaging on extraordinary collection activities. I know that the collection activities sound shocking. I will say that some of the policies that hospitals have do include those collection activities. I think it's just a sort of putting folks on notice. I have not heard about these collection activities being a problem for Vermonters, and I would not want to take away a tool from hospitals. If Elon Musk came to one of our ski mountains and broke a bunch of bones and then left Vermont and we had no way to collect on him, and he wasn't paying or something to that effect. As the healthcare advocate pointed out, there are some bad actors. And if they have assets that can pay their medical debt, we should be able to legally obtain those assets. We talk a lot about affordability. And so there is striking a balance between realizing the economic strain that Vermonters are under. And I think Act 119 and this bill does a really good job of that. We don't want to completely take away all tools from hospitals to collect medical debt. So I would caution folks from prohibiting against actually collecting on medical debts that are valid and can go towards affordability. And then the proactive screening piece would be extremely difficult for us to implement at this time. This would go towards just about everyone. It's for bills over $500. And the way that we try to, the way that we are doing the financial assistance policy now, we need tax documents and we need pay stubs. If we don't have tax documents to determine if someone's eligible, we have to do a calculation of modified adjusted gross income. I just don't know how we do that without, before sending a bill out or before having a conversation with someone. It would be very difficult to implement and very difficult for our financial offices to implement, especially if we are undergoing some other things that we're looking at, like reference-based pricing, global hospital budgets, other affordability initiatives. This on top of it would be very administratively difficult to implement.
All right.
I just want to be clear, the things that you just talked about, even the ones that you agree with or Boz agrees with, you're still preferring that we don't add those now.
I think I think the things that we agree with, so recommendation 1, the adding a notice requirement, it doesn't impact us. We don't have to add the notice requirement, but it does let people know about our programs. So we do support that one. The rest don't apply or we disagree with them.
So I took notes so that I could ask all at once and not interrupt. But I'm just looking for the healthcare advocates. I think I closed the tab, so I won't do it. I clicked on something on their tab that took me to a law. But there was the thing about there was a thing about, here we go. Okay. This part about it was recommendation 3 that you said that patient might consent to it. Could we clarify, would it be amenable for us to, you don't have to answer this right now either, but might it be amenable for us to clarify that it's a soft pull versus a hard pull or whatever Ernie Davis said? I don't know if that's the exact language he used, but something like that. Yeah.
Yes, I don't know enough at this point to speak to it, but let me ask my folks that.
And then the second question is, for the extraordinary collection activities piece, I clicked on 26 CFR. That's what had taken me off the healthcare advocates presentation. And I was reading it and trying to figure out what the reasonable efforts mean.
Yes.
And what criteria Vermont hospitals might use before they engage in extraordinary collection activities. Because if Elon Musk came to Vermont and broke every bone in his body and survived and owed UVM a lot of money, I would be fine with you trying to take Neuralink or Tesla from him or something like that, but if someone makes $49,000 a year instead of $48,000, whatever, the 400%, I might be getting it because I can't see behind me right now, but and that would trigger an extraordinary collection activity that wouldn't seem fair to me. So I guess I'd like to know more about what the reasonable efforts are and what are the thresholds at which a hospital might jump to this point. of placing a lien on a senior's property or something. So I don't know. I guess I just would like to know a little more about what the reasonable efforts are before giving up the idea of prohibiting extraordinary collection activity.
Yeah, so I think the reasonable efforts under Medicare, and I'm not sure if that's the one that you're referring to, the
So
42
figure it
CFR.
out, yeah.
My understanding is that is the hospital making contact for 120 days. So 3 months of a collection period is what Medicare requires, and it's generally phone calls, mail, that sort of thing. To do the extraordinary collection activity, my understanding, and again, I'm gonna look at Emma for this too, but a hospital would have to like go to court. And the thing about medical debt is it's not attached to anything. So in order to attach it, like, so unlike your house or a car where the person can just come and take it because it's attached, medical debt is not attached to anything. In order to attach it to something, the hospital would have to go to court and go through a court process.
So there would be a due process with a judge evaluating things and determining if it's fair to attach a lien to a property over the amount of the debt, et cetera.
There's definitely a process. I don't know how much. I would have to go into the depths of my memory.
Or maybe we can
Well,
take time to
but-
learn a little more, that's all.
But I would want to understand that these actions are an actual problem versus the concern that I heard from the healthcare advocate, which was this is put in front of a consumer and that stresses them out as opposed to the actions actually happening. And if it's just put in front of the consumer and stresses them out, I think hospitals can work on that. And we would also want to be able to go after Elon Musk if we have to.
Yeah, and the last question, sorry, yeah,
I'm
it's-
sorry.
it is an
Can I
interesting,
just give this Elon Musk thing to me, please?
luckily JD Vance didn't break any bones.
Yeah.
The last serious question, is the piece around screening patients. I heard you say that it would be a bit much to jump to that at this time because the hospitals are possibly going to be asked to do a lot of things in this next coming fiscal year based on what's before us. But what I'm wondering is if there, and you don't have to answer this today, but might there be an opportunity to look at this when we are looking at other accountability measures and reference-based pricing and all that in that other bill? Not the one we're taking, the state plan one that I think got sent to the committee today.
Yeah.
So you don't have to answer that now, but it's something to think about because maybe there's a way we can weave this, like if the hospitals are looking at other practices, maybe they could look at, is there a way to address this down the road versus like us asking you to do it immediately on top of all this other stuff. So
Yeah, I appreciate that because it is a lot. And I think the other thing I'm just stuck on is I don't understand how we get people's financials information before we're like, I'm just trying to figure out how the process actually works too. Like, would we have to call every patient and ask for their tax forms? That seems like.
it sounds like it says here, if they're uninsured, if they're enrolled in, this is Oregon, if they're uninsured, if they're enrolled in a state medical assistance program, or if they owe the hospital more than 500. But it sounds like you were saying most people are going to owe the hospital more than 500. So yes, I think we need to learn more about how Oregon does it.
Yeah.
Before I'd be comfortable just asking you to do it on top of, I'd rather you do reference-based pricing right now, honestly, than worry about this.
Do you
Anyway,
have any concerns about the removal of behavioral?
I support the removal of behavioral.
Okay.
Since behavioral or mental health, so just take out behavioral.
Yeah.
What's that? Well, just,
I support it.
yeah.
Let's do it.
Let's make life easier for the reporter of the bill.
Any other questions for Deborah?
I just like, I can't imagine you not having that information, the hospitals not having that information.
Tax returns?
No, but they practically ask for your firstborn when you go in too.
But again, it's all based on tax information, modified adjusted gross income.
Okay,
That's what
okay.
your income is based off of is tax info, and we don't ask for that.
Okay.
Thank you, Devin.
Yeah, thank you for enduring all the.
Yeah. We have Chris Delia with us. Hi, Chris. We never see you in this committee. Welcome.
Aren't you lucky? For the record, Chris Delia, President, Vermont Bankers Association. Good to see you all. It's probably been about 13 or 14 years since I've been in the healthcare committee. So yes, thank you. So we're supportive of S-27 as it came across you from the Senate. We worked with the treasurer and other interested parties on the definition as it pertains to medical debt in this bill, just to ensure that blanket credit card or personal loans or home equity loans were not considered as part of medical debt. Everybody was in agreement with that. Senate committee agreed with that. So that's how the bill comes over to you, and that's what we support.
Oh,
Sorry, I just want to clarify, like, so forgive me for not knowing banking well.
No.
It's like I know it just based on my own personal experience
Yeah.
dealing with banks, like not knowing it professionally. But do people use their home equity loan to pay medical debt, or is that not allowed? I thought home equity loans were only allowed for home improvement and stuff.
No, as long as you have the income verification, you can go ahead and use it. You can use a personal loan that way. You can use a credit card that way. And the challenge that we ran into is we don't know what your end use is. So I don't know when you take out that loan, are you using it for medical debt? Are you using it for something else? So we see that as a reportable item as compared to what you're trying to address in the bill, which is clearly medical debt. So you see, for example, a medical debt credit card would not be something that would be exempt in the bill, but other credit card debt would be because it's all commingled. We don't know 5 months ago whether you use that for medical debt or not. Home equity is just pulling equity out of your house to use it for some purpose. It's not using it to specifically go back into the house.
Right.
Often people do that to
Yes.
make home improvements, but you are not restricted to that use.
Thanks for explaining, because I understand better now why we wouldn't want to go down that road, because it could get complicated and it could open the door to fraud if someone has mingled money, et cetera.
Yeah.
And we don't want to we're trying to keep it clean, it sounds like, and start easier, so to speak, or, okay.
thank you.
Yeah.
Any other questions?
Thank you.
Well,
Way too easy. Way too easy. I'll see you in another 15.
It might be sooner, I don't know.
we try to stay away from things that have to do with the banking.
I greatly appreciate. Can you share that with the rest of your colleagues?
There you go.
Thank you very much.
All right, so I think we're all set for the, yes? Okay, just in case I hadn't had an updated agenda.